Hello, everyone. My name is Andrea Reyes. I work at Columbia University's Comprehensive Cancer Center, and we have a really great program for you tonight. It's all about colorectal cancer and what you need to know. Um, Below on the screen are the names of the different panelists. We will be introducing them one by one. Welcome again. I would like to give special thanks to our moderators, Calvin Martin, who's a deacon at the Convent Avenue Baptist Church. He's a past Grand Master of Prince Hall Masons from New York State, and he's a founder of Brother to Brother, which is a prostate cancer support group. Again, special thank you to Ruth Ellerbe, who is also online, who is past Imperial Commandress, Imperial Court, AUX, and AEAONMS Incorporated. She's a 25-year member of the New Jerusalem Worship Center. She's a business manager at Prince Hall Colonial Park Daycare Center and a retired human resource employee and benefits manager at New York Presbyterian Hospital. Today's discussion. So good evening again, and thank you for all of you for attending tonight. Tonight's presentation is called Reducing Your Chances of Getting Colorectal Cancer. Our panelists include a colorectal cancer survivor and 2 physician experts. After the slide presentation, there will be a fairly good amount of time for you all to ask your questions by typing your question in the chat or even asking verbally. First, we would like to thank our sponsors and our community outreach and engagement team.
We are delighted to have 4 sponsors who are well known in our community because of the work that they do. Number 1, we have the Prince Hall Medical Foundation of the Most Worshipful Prince Hall Grand Lodge of the state of New York, where Most Worshipful Walter C. King serves as Grand Master, and Right Worshipful Gregory R. Smith Jr. serves as Director. Number 2, we have the New Jerusalem Worship Center, which is located in Jamaica, New York, where Bishop Calvin Rice serves as pastor, and where my co-host Ruth Ellerbe worships. Number 3, we have the Eureka Grand Chapter, Prince Hall Order of the Eastern Star. Sister Diane J. Smith serves as Grand Worthy Matron, and they are located at 454 West 155th Street in New York City. Our 4th sponsor is the Imperial Court, auxiliary to the ancient Egyptian Arabic Order Nova of the Mystic Shrine. Their headquarters is located in Memphis, Tennessee. Daughter Jacqueline Brown at Dabadoo serves as Imperial Commander. We extend a hearty thanks to all 4 of our sponsors. For this presentation, you will see 5 faces: mine, my co-host Ruth, the survivor, and 2 doctors. But all of you know, in order for a program of this magnitude to be successful, a lot of work is done behind the scene. And we are fortunate to have a team from Herbert Irving Comprehensive Cancer Institute Center working behind the scene to ensure the success of this program. And there's a smaller group within that center. It is a community outreach engagement. They are not only the backbone of this program, but they are deeply involved with approximately 4 virtual health seminars per month. Additionally, they work extremely hard at trying to narrow the health disparities within our community. In your far right-hand corner, you see Karen Smith. She is an RN, registered nurse, co-director. I really call her the CEO because she is my go-to person. On the left-hand part of your screen, you see Andrea Reyes. She has a Master of Art degree from Columbia University. She's the manager of health education and outreach. And if you ever have a seminar or a health symposium and you need someone to speak to you about cancer, she is your person. Last, we have Maya Lipsman. She has a Master of Public Health from Columbia University, and she is the research project coordinator. She's also our IT person. And because of the pandemic and everything that is being done now is being done virtually, she is in more demand now than ever. This presentation would not have been possible without their help. Let's give them a standing ovation. Thank you so much for all that you do.
Thank you, Calvin, so much.
And by the way, they were very reluctant to have this part as a part of this program, but the group thought it was important. Now we are ready to hear from our survivor, Mr. Harmon Kennedy. Mr. Kennedy was diagnosed with colorectal cancer in September of 2011. After surgery and chemotherapy, his cancer has remained in remission. He has become a mentor and advocate for others who are battling colorectal cancer. He serves as a volunteer for the American Cancer Society. Currently, he is a member of the Bronx Oncology Living Daily, which is BOLD program. This program provides support to him as a survivor. It also enables him to provide support for others who are in need of support. This work is very rewarding to Mr. Kennedy. He is employed at Montefiore Medical Center in the Bronx. Mr. Kennedy has been an active member of the Convent Avenue Baptist Church in Harlem for more than 10 years. He serves on the male usher board at the church and also served on the security committee. He is married to the lovely Darlene Kennedy. Harmon, you're on.
Okay, thank you. Thank you for that introduction. I really appreciate it. I'm so thankful for all of you for inviting me to this forum. I really appreciate it. Like Deacon Martin said, I was diagnosed with colon cancer back in September of 2011. I'm coming up on my 10th year as a survivor, and my cancer is still in remission. It has been so rewarding for me to help others. When I was diagnosed in 2011, it was very devastating to me because I had no symptoms, I had no sickness, I had nothing. I actually just went to my primary care physician for a physical, and she recommended that I have a colonoscopy when I was 49. But I reluctantly talked her out of it. And she said, next year when you get 50, you're going to definitely do it. So when I went back at 50, and she made me go and take the this is something that happens to me too from the cancer. Sometimes I get chemo brain, and my brain, I want to say stuff, but it doesn't come out sometimes right. So I went and took I can't even think of the word. But anyway, I went and took what is the word?
Colonoscopy.
Colonoscopy, thank you so much. When I went and took the colonoscopy, my doctor called me 2 days later and told me that I had colon cancer, and knocked me off my feet. It was the worst thing I've ever heard, because they actually told me that my cancer was very aggressive and that I needed to get medical treatment right away. I thank this doctor to this day for moving as quickly as he did, because he had also told me that within a month, maybe 2 months, it would have spread so badly that I probably wouldn't have been able to survive. So I thank God for his grace and being able to let me catch this at as early as I could, where I was able to survive. I went through extensive chemotherapy for 6 months. I had a port in my chest, and I also had to take the chemo, was pumped into me for 3 whole days. I took this chemo home with me every other week for 3 days, and this just pumped into my system. Once my cancer was in remission, all I wanted to do was just help other people, because I knew how devastating it was for me, and I just wanted to reach out to others. So I started volunteering with the American Cancer Society. And once I started volunteering with the American Cancer Society, it was so rewarding. They actually gave me a job, a seasonal job. And then I didn't have anything, but it was the American Cancer Making Strides Against Breast Cancer Walk that I was part of. And during the winter, I had nothing to do. So I started volunteering with the hospital. And when they heard about my cancer story, they put me in contact with the people at the BOLD program. And since I've been at Monty, I've been with the BOLD program now for at least the last 8 years. And being with the boat program has been rewarding and very difficult for me. Because being a survivor, I have lost so many other people to this disease. But I know that I have made a difference in their lives just by being there for them during their difficult time. And I'm going to continue to do that as long as I'm here. I want to always be able to participate in forums like this, speak, and tell people my story, because I am one of the lucky ones. Because during the time, over the last 10 years, I have lost so many people to this disease. And, I'm just still grateful to be here. I'm very grateful that I've had them in my life and just been able to be there for them during this difficult time. So I really appreciate you guys for having me here and letting me share my story. Thank you.
Thank you, Harmon.
Good evening. It's my honor and pleasure to introduce our two esteemed physicians, and the first will be Dr. Richard Younge. Dr. Younge is a family physician and researcher and provides medical and preventive care to urban underserved racial and ethnic minority populations. He is a director of the Center for Family and Community Medicines at Columbia University that has a family residency program and a clinic to provide care to Spanish-speaking immigrant adults and their children. Today, Dr. Younge will be talking to us about screening methods for colorectal cancer. Okay, Dr. Krigel, Anna Krigel, is a gastroenterologist at Columbia University Medical Center, and she is a specialist in colon cancer screening, early onset colorectal cancer, and colonoscopy quality. Today, she's going to be speaking to us about colon screening and colonoscopies.
Thank you, Dr. Krigel. It's all yours.
Okay, thank you so much. And thank you all for having me. Apologies in advance if you can hear my toddler in the background at some points, but hopefully I can speak over him. So we can go into slides that we prepared about colon cancer screening. I'm going to be talking first about when we should begin colon cancer screening, because there have been some changes in the guidelines recently that I'll go over. And then I'm going to be talking about the methods of colon cancer screening. So let's get started. So just some facts about colon cancer. It is the third most common cancer in the United States in both men and women, and the second deadliest cancer in the US in both men and women. 90% of cases occur in people over the age of 50. However, that does mean that 10% of cases happen in those younger than 50, and that has prompted some of these changes in the guidelines that I'm going to go over. Rates of colon cancer are slightly higher in men than in women, and African Americans have the highest rates of colon cancer and the highest death rates from colon cancer among all groups in the US. And so what are the benefits of any cancer screening program? Well, the first is preventing that cancer from happening in the first place. And the second is improving the survival from cancer if that cancer does unfortunately happen. And so in terms of cancer prevention, the way that we accomplish colon cancer prevention with colon cancer screening is we can actually find precancerous lesions or polyps in the colon, and we remove them during colonoscopy, and that prevents colon cancer from ever happening at that site. And the second way, the way that we improve survival from colon cancer with colon cancer screening, is that we accomplish early detection of these tumors when treatment is still able to treat and even cure people. So that is the benefits of the screening that I'm going to be talking about. Compared to other races, African Americans do have lower screening rates, higher incidence rates of colon cancer, meaning they get it more often. They do have an earlier age of onset. So when the cancer happens, it happens at an earlier age for African American patients. African American patients tend to have worse survival compared to other races, higher rates of later stage at diagnosis, meaning they're presenting later oftentimes, and a higher proportion of cancers before the age of 50 compared to other races. So because of this, the Multi-Society Task Force, which is a group of societies, of gastrointestinal societies, the American Gastroenterology Association, the American College of Gastroenterology, these societies have gotten together and created guidelines about when we should begin colon cancer screening. And as of right now, this is what the Multi-Society Task Force says. This is a group of GI societies. They say that they recommend screening begin in average risk people, meaning those without a family history of colon cancer or any other condition that might put them at increased risk of having colon cancer, that screening begin at age 50. However, in African American patients, screening should begin at age 45, so 5 years earlier. And that is, based on the evidence that I just put forward about having a higher proportion of patients presenting before the age of 50, presenting at later stage in the disease. And so it's of low quality evidence because we don't have high quality studies that have shown that this strategy will effectively prevent colon cancer or even improve mortality rates from colon cancer in African Americans. But based on the numbers, we still say, okay, we should be starting earlier in African Americans. And this is how the guidelines currently stand for the Multi-Society Task Force. However, in May of 2018, the American Cancer Society, which is a different group that creates guidelines on colon cancer screening and cancer screening in general, actually recommended that we should begin colon cancer screening for all average risk patients beginning at age 45, not 50, but 45. And the reason for this is that we have been seeing rising rates of early onset colorectal cancer for about the past decade. And so we are seeing colon cancer happening earlier and earlier. And so for this reason, this society got together, looked at the numbers, and decided we should be screening. We would be able to prevent more cancers and more death from colon cancer by starting at age 45 instead of 50. And so that is why in October of 2020, the U.S. Preventative Services Task Force, which is the governmental task force that creates guidelines on cancer screening. And this task force is important because this is what the insurances go by. And so when the U.S. Preventative Services Task Force makes a screening recommendation, that is when the insurances decide that they will now start paying for the screening at the ages that are recommended by this task force. And so in October of 2020, the USPSTF did release their draft recommendation based on, again, the evidence that early onset colorectal cancer is on the rise, that we should actually begin at age 45 instead of age 50. And it looks like this draft recommendation will become finalized in the early parts of 2021, and that the Multi-Society Task Force will soon follow suit. And so now for all people, not just African Americans, we're gonna start now recommending colon cancer screening begin at age 45. And just a word on when we should stop screening. So people who are in good health and with a good life expectancy of more than 10 years should continue regular colorectal cancer screening through the age of 75. Then for people who are ages 76 through 85, the decision to be screened should actually be based on personal preference, life expectancy, so how long the patient is expected to live after this age, and overall health, and prior screening history. So from ages 76 through 85, the societies recommend that it really be a conversation between the patient and the doctor based on all of these factors, whether or not to continue screening. And people over the age of 85, we generally say colon cancer screening is no longer necessary. Okay, so now I'm going to start talking about the methods of colon cancer screening. This list is from the American Cancer Society. So the American Cancer Society recommends 6 different methods of colon cancer screening. So when you begin screening at age 45, any of these methods will do. And I'm going to go over a select few of them in terms of the risks and benefits, but just the list here includes fecal immunochemical test, which is a stool-based test that's shortened to FIT, and that's done every year. High sensitivity guaiac-based fecal occult blood test, which sometimes is shortened to FOBT. That is another stool-based test that's done every year. Multi-target stool DNA test. So that's a combination of FIT plus a DNA component to it. And the brand name for that is Cologuard. They have many, many advertisements, so you may have heard of that with commercials. That is one that's done every 3 years. And in terms of what we call structural examinations, or those that we do visually of the colon, colonoscopy is done every 10 years. CT, or computed tomography, it's a type of radiology examination. CT colonography is something that's done every 5 years, and flexible sigmoidoscopy every 5 years. I'm not going to be talking about CT colonography or flexible sigmoidoscopy. These are structural examinations that have fallen out of favor for a few reasons. They're not offered many places, and they're not as practical as the other 4 methods. So I'm only going to be talking about the 3 stool-based testing methods and colonoscopy. So the first stool-based method that I'm going to be talking about is the FOBT test, or fecal occult blood test. So this is a test that detects microscopic blood in the stool. So it's not necessarily that if you had blood in your stool, you would be able to see it. It can be microscopic. And so this test picks that up. If you have this test done, you're required to provide 3 stool samples from 3 separate days. And in order to really have it be as accurate as possible, if you're having this test done, you really need to limit what you're eating. Meaning, not red meats or other things that have a lot of iron in them. And that's because this test detects, iron specifically. It has to be done every year. And, the downside, aside from those other things that I mentioned, that it's 3 stool samples, that you have to have a restricted diet during those 3 days, it's not as sensitive compared to the other 2, FIT and Cologuard, meaning it doesn't pick up as many early colon cancers as the other 2. So FIT has really come into favor. Actually, if we can go back to FIT, FIT has really come into favor as the preferred stool test if you're going to do a stool test. This test specifically for human blood cells in a stool. So for that reason, there's no dietary restrictions when you have this stool-based test done. You only need 1 stool sample. This also, though, has to be done yearly. Fortunately, there's a low one-time cost for this test. It's very cheap. And there are fewer false positives compared to Cologuard. And then Cologuard, which is the last stool-based test, is, as I mentioned, a combination of FIT and DNA testing. It's done every 3 years instead of every year because it is more sensitive than FIT. So meaning that it does pick up slightly more early colon cancers than does FIT. However, because it's more sensitive, it picks up more false positives, meaning that the test could be positive more often when there isn't a large polyp or a tumor present in the colon. It also only requires a single stool sample. And unfortunately is more costly than FIT, a lot more expensive. And so for this reason, as I mentioned, FIT is really the favored stool-based test, if stool-based testing is the way to go for you. And just so you know, if any of your stool-based tests are positive, that prompts a colonoscopy. So what is the next step after a positive stool-based test? It is colonoscopy. And so I'm going to talk about colonoscopy because many people just go straight to colonoscopy for colon cancer screening. And there are a few reasons for that. It accomplishes direct visualization of the colon. You can detect cancer and all precancerous lesions or polyps with this test, meaning that the stool-based tests pick up most early tumors and some advanced, meaning large polyps, but not small polyps that we can find on colonoscopy. And on colonoscopy, the other advantage is that you have single session diagnosis and removal of precancerous polyps, meaning that when you are doing the exam, you find a polyp, you remove it at the time that you see it during the colonoscopy. It's not necessary to have another procedure afterwards. We find a polyp, we remove it during colonoscopy. The other advantage of colonoscopy is that, as I mentioned, it's done every 10 years. So if you have a colonoscopy and you have no polyps, you're good for 10 years. Whereas if you have a FIT test and it's negative, you have to have it done the next year and the next year. So, and of course, colonoscopy, which I'll go over the process of having it done, there are, disadvantages to having the colonoscopy. You need to, first of all, prepare for your colonoscopy by cleaning out the colon. And so preparation for colonoscopy is the unpleasant part of the procedure. The procedure itself, people generally don't mind because you are under anesthesia and you're asleep and comfortable and monitored the whole time. But the preparation for colonoscopy can be unpleasant. And so, I'll just go over the basics of it, which is that in the days leading up to colonoscopy and the 2 days leading up to colonoscopy, your doctor will ask you to start following a low fiber diet. That is because foods that are high in fiber are harder to clean out of the colon in a timely manner. And so we start to say, all right, follow a low fiber diet, avoid fruits and vegetables, seeds, nuts. These are foods that are hard to clean out of the colon. But there are plenty of foods that you can still eat in those days. You're also going to want to know in the days leading up to colonoscopy if all of the medications that you take are safe to be taken during colonoscopy. Specifically, blood thinning medications may need to be held. And that's because when we do remove polyps, there can be some bleeding at the site. And so we ask that those blood thinning medications not be taken in the few days leading up to colonoscopy. And then in the night before and the morning of the procedure, you're going to drink a large amount of a liquid laxative that your gastroenterologist will prescribe to you and send to your pharmacy. So on the night before, you'll drink the first half. And it takes, about 1 to 2 hours. You'll consume the first half of this liquid laxative. The idea is that it's going to give you diarrhea. And so you'll have diarrhea several times over the course of the night, but hopefully you will get sleep and be able to wake up in the morning and drink the second half of the liquid laxative and finish that a few hours before the start time of your procedure. And we ask that you finish it a few hours before the start time of your procedure because that way you will not be having diarrhea on your way into the procedure. You'll be cleaned out. And by the end, it'll just be clear that's coming out and you'll be ready to have the procedure. So now that we've passed the unpleasant part of colonoscopy, I want to sort of prepare you for what it would be like on the day of your procedure. So you come into the endoscopy suite and the nurse and the anesthesiologist will do a medical history interview with you, just confirming your past medical history, the medications that you take, any reactions to anesthesia that you've had in the past, they want to be prepared for. Then your doctor, your gastroenterologist will come in and do the informed consent with you. So the doctor will go over the risks and benefits of the procedure, and then you'll sign off that you understood that conversation. Then you'll have an IV placed. So just a small needle goes into the vein so that then you can receive the sedating medications during the procedure so that you're asleep and comfortable. Because you are getting sedating medications for the procedure, we do require that you have someone who can pick you up and bring you home from the procedure. That person does not need to be present the entire time, does not need to bring you there, just needs to be able to pick you up and bring you home safely. And that's because you're getting sedating medications. And, because you're getting sedating medications, we also generally recommend that you take the day off from work that day. You'll be able to go home, relax for the rest of the day. Don't make any major life decisions. Don't operate heavy machinery or drive, that kind of thing. But by the next day, you're good to go back to work. And actually immediately after the procedure, you're able to eat and drink normally as well. And so what are we looking for? So during the procedure itself, a flexible scope with a camera at the end is inserted through the rectum, and it looks through the whole colon or the large intestine. And what we're looking for are small polyps or growths that can be precancerous. And so when we find these polyps, we remove them at the time of colonoscopy. I've got a picture here of a small polyp and then one of a larger one or more advanced polyp. And there are a few different kinds of polyps. Adenomas, when you get your report, if you've had an adenoma, that's a benign polyp that does have precancerous potential. So it's good that we found it and removed it. Some polyps are what we call hyperplastic polyps. Those actually have no precancerous potential. And so, your doctor afterwards will let you know if, once the results come back, if it was an adenoma or a hyperplastic polyp. And advanced adenomas, which I had mentioned before, are larger polyps that are at higher risk of becoming cancers. And that's, what we're really looking for sure, is finding those advanced adenomas and removing them before they become tumors. How do we accomplish the removal? So this is just a picture of a Snare polypectomy. So when we do see a polyp, we can either remove it with a small forceps, a small, it's like larger. We put a tool through the scope that has a snare at the end. We wrap that snare around the polyp, close it tight, and then we are able to just snip off the polyp like that and suck it back into our scope and send it off to the lab and see what kind it was. There's always a little bit of bleeding at that site, as I mentioned, but it resolves pretty quickly. Now, this is very important. Now, I showed you pictures of how small the polyps can be. And so you can imagine if there's stool left in the colon, it's very hard to be able to get a complete exam. We need to be able to see every surface of the colon in order to be sure that we've ruled out any small or even larger polyps. And so this is an example of an excellent prep. Then we have a good prep, a fair prep, and a poor prep. And so if there is a poor prep, meaning there's a lot of stool left over the colon and we can't see many of the surfaces of the colon, we do need to repeat the exam. A fair prep, we generally want to repeat it about a year later. A poor prep, we want to repeat it within 6 months. So it's extremely important to have a good prep, follow the instructions that you receive from your doctor to a T about how to prepare. And by the end of prepping, like I said, everything that's coming out should be clear. And that's how you know you've got a good prep and your doctor is going to be able to accomplish a good screening exam. And what to expect after your procedure. So afterwards, you're going to recover from the anesthesia for about 30 minutes in the endoscopy suite. You can resume a normal diet immediately afterwards. You'll receive a report about the procedure and the findings from your doctor, complete with pictures of your colon and any polyps that were found. Like I said, if no polyps are found, the next colonoscopy is not needed for another 10 years, which is great. And if polyps are found, you may need to have the colonoscopy repeated sooner. And so your doctor will let you know. Once the polyps are sent off to the lab, if they come back as adenomas, if you have 1 or 2 small adenomas, you're actually still good for 7 to 10 years. If you have 3 to 4 small adenomas, you're good for 3 to 5 years. If you have an advanced adenoma, one that's larger and seemed like it was on its way potentially to becoming a colon cancer, you're good for 3 years still. So that interval will be advised to you by your doctor once the results come back. And then you'll know that come 3 years, 5 years, 7 years, you should be asking your doctor again about having your next colonoscopy. And I think that's it for my slides. These look like to be some colon cancer screening resources that we have at NYP. So thank you.
Thank you, Dr. Krigel. So we have 2 resources. If you are interested in scheduling or asking questions about colon health or seeing a gastroenterologist or scheduling a colonoscopy, please, I advise you take a snapshot. We can always put these numbers again at the end in the chat, but you can take a picture of the screen or do a screen grab so that way you have this information. The very first number is for people without health insurance. There we have at Columbia Presbyterian, the Manhattan Cancer Services Program, and you can get free screening. You can get fit kits done, if you're a woman, you can get a mammogram done, and also pap smears done. And for people with health insurance, we refer everyone to the Center for Digestive Health. And the number below is 212-342-1155. Again, please snapshot the screen if you would like this information. Okay. So again, please write your questions into the chat. We will be responding one by one. We thank you so much for your participation. It's not over. We would love to have a discussion with you. If at some point you feel that you didn't have time to ask your question, or you would like to have your question responded to at a later time, this is our email address. It's columbiacancercoe@cumc.columbia.edu. Please feel free to also take a snapshot of this email if you would like to use it in the future. You can contact us directly. And again, this is more of our information. This is our telephone number, our email. We have a website where we have other workshops up. Here we go. So I'm going to stop screen sharing. I'll give you another couple seconds if you would like to take a snapshot of this information. And we'll stop screen sharing and we'll enter our discussion. Okay, stop our screen share. Hello, everyone. Thank you again for remaining. And I'm going to leave this to Doctors Krigel and Young to answer all of the questions that come in. Thank you so much.
Well, thank you for that. Was a very comprehensive and excellent presentation about colon cancer screening and risk factors. There is one question that has come in about having a family history of colon cancer or other cancers, and how often should people be screened? That's actually a question that's very near and dear to my heart, in that I have a family history of colon cancer. My father passed from colon cancer, and my younger brother passed away from colon cancer a few years ago. So I know the answer to that, which is that colon cancer screening should be done more often in somebody who has a family history. The recommendations that I've been aware of are to do the colon cancer screening every 5 years if you have a strong family history. And family history is certainly one of the major risk factors for colon cancer, along with African-American race, obesity, smoking, but family history is a very strong problem as far as colon cancer is concerned. Would you like to add anything to that, Dr. Krigel?
Yeah, so absolutely. So yeah, we've had a few questions about family history. So I'll just address, so in terms of when to begin, do you need to be screened earlier if you have a family history? So if you have a family history of colon cancer in a first-degree relative, meaning mother, father, brother, sister, you should begin screening at age 40 or 10 years before that relative was diagnosed, whichever comes sooner. So if your mother was diagnosed with colon cancer at age, when she was 40, you should begin screening at age 30. If your father was diagnosed at age 56, you should begin at age 40. So if you have a family history of a first-degree relative with colon cancer, you should begin screening at age 40 or 10 years before the age of diagnosis, whichever comes sooner. If you have a second-degree relative with colon cancer, a grandparent, an aunt, an uncle, there actually is no recommendation to begin screening earlier. However, your parents should, or, if it was a grandparent, and if your parents have also an advanced adenoma, one of those large polyps that we talked about, that's another reason to get screened earlier, because we do believe that that was on its way to becoming a tumor or a colon cancer. And then, yes, if then you've had a family history of colon cancer and a first degree relative, your doctor will generally recommend that your interval for screening should be every 5 years instead of every 10 years.
And do you know anything about the CHEK2 mutation?
No, I will quickly look that up. I don't know the answer to that one. But there are some questions about dietary questions. And so there are some foods, basically a diet that is rich in fiber, high fiber diet is generally very good for the colon. And so that is a diet that's well known to help at least keep a healthy colon and potentially prevent polyps and colon cancer. And then a diet that's high in red meat consumption can be a cause of, or can be associated with colon polyps or colon cancer.
Yeah, also interestingly, in primary care, we take care of a lot of folks with diabetes. That's also an increased risk factor for colon cancer. I don't know if there's really information that says how well your diabetes is controlled, but certainly there's an association with diabetes and a higher risk of colon cancer. Vegetarian diets are good. Red or processed meats that have a lot of nitrates in them are probably risk factors for colon cancer. And people who themselves have some of the inflammatory bowel diseases that we see, such as ulcerative colitis, Crohn's disease. Those are other diagnoses that if I have a patient with those conditions, that would also be an increased risk. Certainly encourage people, as I mentioned, to stop smoking. Primary care, one of the things that we really stress in terms of cancer prevention is cigarette smoking. And that is something that is a risk factor for colon cancer, for lung cancer, breast cancer, cervical cancer. So, it's just in terms of preventing many different kinds of cancers. Cigarettes are bad actors, and something that we encourage people to stop.
There were questions about how can a person, or why does a person get colon cancer, and what are the symptoms? And so, first of all, colon cancer happens because of mutations that occur just in the tissue of the colon that result in uncontrolled or unchecked cell growth in the colon. And that's how, a polyp and then a tumor develops. And it, first comes from a polyp and then grows larger into a tumor. And so that's why, since we know about this pathway between polyps and developing into colon cancers or tumors, we can catch these at earlier stages before they become cancer. Some of the symptoms of colon cancer. Having a change in your bowel habits. So, if you develop a change in your stools that you notice, if you notice blood in your stool, if you have weight loss, if your blood work is checked by your doctor and you are anemic, that is potentially a sign of colon cancer as well. And by weight loss, I should say unintentional weight loss. You've noticed that you've lost weight and you didn't mean to. So those are some of the symptoms. Anything to add to that, Dr. Young?
Yeah, I was also going to mention, very specifically changes in your stool, meaning that going from, having, sort of more regular foreign bowel movements to ones that are maybe thinner or, having, some of the later symptoms can also be pain, cramps, but blood in the bowel movement is the one that, should be a very frightening symptom, and for many people it is. But that would definitely be something to bring to the attention of your doctor. So question, what advice would we give to somebody who believes that they might have colorectal cancer but is afraid to ask? I think that that can be a problem that relates to a delay in diagnosis. Be interested, I think often people say, well, I don't want to get a screening test, or I don't want to, go for a mammography because I'm afraid of what I'm going to find out. And, when I'm having those conversations with my patients, I try to, reassure them about treatment that's available should the answer be something that they didn't want to hear. But I also talk to them about the importance of early detection and screening, that with many of the cancers that we do these screening tests for, there's a real advantage to finding out sooner rather than later. There's excellent treatment available for colon cancer when it's caught in a relatively early stage. Again, going to family history, my brother was a survivor for 10 years, as we heard earlier. So long-term survival is really possible. So I try to talk about people's fears. What is it that they are worried about? And as much as possible, try to allay those fears. Some people do have some fear about the actual screening procedure. I think that Dr. Krigel was really helpful in terms of, making the colonoscopy experience, it's not something that's really scary. The prep is sometimes a little inconvenient and uncomfortable, but it's a very benign, I think, easy procedure, and I can speak directly to that, having had it a couple of times myself.
Yes, and just to answer someone quickly, you do lie on your left side for the procedure. Like I tell people, you're gonna fall asleep on your side. So you just roll onto your side on your left side. So there was a question also I saw about, let's see. Oh, yeah, and then right, and then why might a person have a lot of polyps without a family history? So yeah, so how fast do polyps develop? So if you have an adenoma, which is one of these small potentially precancerous polyps, that will turn into a colon cancer 25% of the time in 20 years. And so that's where, and it'll turn into a colon cancer in 10 years, about 10% of the time. And so that's why the intervals are what they are. It takes about 10 years for an adenoma to grow into something larger, where it could be at risk for a colon cancer. And so that's why we say 10 years is a safe interval. We don't let people wait 20 years, because at that point, many of these adenomas could become cancers. But after 10 years, it's unlikely that any of them would become large cancers that would have spread. And then there are conditions, genetic conditions, people at higher risk for polyps and for cancer. And if you have a family history of those, you should certainly get genetic testing. And we actually have a great high risk GI genetics group at Columbia that sees patients for all kinds of colon cancer genetic syndromes. For people who have negative genetic testing but have a lot of polyps, that is probably due to some genetic mutation we just have not yet discovered. And so when people do have a lot of polyps over and over again on colonoscopy and have negative genetic testing, we treat that person as if they do have a genetic polyposis syndrome, and we do very frequent screenings on those people yearly.
I can just pop in here. There's a couple of questions that are really asking about why there are higher death rates among African Americans, and also what are the differences, or what causes more colon cancer in African Americans?
I think that in terms of the higher death rate, I think that's often an issue of disparities in early detection, and the lack of access to primary care and preventive care, and the ability to get periodic screening. And I mean, that applies across a number of different types of cancer. But I think the higher death rates, in my mind, certainly go to fact that African Americans, people of color, often have less access to screening programs. In terms of why it's more prevalent or more common, I don't really think I've read any literature about what exactly is the cause. I mean, it could be some of the things that we've mentioned in terms of lifestyle are more prevalent. There's cigarette smoking, diabetes is type 2 diabetes is more prevalent in younger African Americans, so that may be a causative factor. So it may just be that the risk factors are more common.
Yeah, I mean, I think it's mostly that, and then possibly some contribution from a genetic predisposition, but I think most of it is going to be external factors, environmental risk factors, and then yeah, absolutely the higher death rates are just the lack of access to preventative care, and that's why people end up presenting at later stages, and that's a big risk factor for not surviving the colon cancer. Someone asked about also, could hemorrhoids be polyps? Hemorrhoids are actually entirely different from polyps. Hemorrhoids are enlarged veins or engorged veins that happen in the rectum or in the anal area that can develop just from pressure in that area over time. And so those are not worrisome for being polyps or precancerous at all, not related.
I just realized there's a whole trove of questions in the chat as well as the Q&A. Yeah.
Someone said, "Oh, red meat or all meats, all animal meats." It's red meat.
It's red meat, particularly.
Yeah. Mm-hmm. And can it repeat itself after detected? Okay, so once a polyp is found and removed, that if it's completely removed, that polyp should not repeat itself in that spot. But having a polyp, a precancerous polyp, does put you at risk for having polyps again in the future, potentially in a different part of the colon. And so for that reason, that's why if you have a polyp, we recommend shorter screening intervals, 5 years, 7 years, rather than 10 years. Because your colon has shown itself to be, developing polyps. And so yes, polyps can, you can have more polyps on your next exam potentially, but generally it's not the same polyp.
There is a question, is there a less invasive way of detecting colon cancer than colonoscopy? I mean, just not really. I mean, there are less invasive ways of screening for colon cancer. So the blood test, the stool tests, they are tests that detect blood or DNA in the stool, but they don't tell you if you have colon cancer or not. They're not diagnostic. Whereas colonoscopy is really as we call it in medicine, the gold standard in terms of screening and being able to diagnose colon cancer. I mean, there are methods of seeing colon cancer. You can see it on X-ray. You can sometimes see it on CAT scan. But in terms of the best way to actually see and find it, screening procedure that you're going to do for lots of people, colonoscopy is really the best method. And if by invasive, you're sort of thinking about the prep that you have to go through for detecting, for having a colonoscopy. Some of the X-ray methods that used to be used, the CT scanning, you still have to go to prep in order to do those. So you don't get out of doing the colonoscopy prep.
Yeah, that's why I was saying that the CT colonography is not so practical. It's you still have to do a whole prep to clean out the colon, and then when you do have the exam itself, if it detects a tumor or a large polyp, you still need to have a colonoscopy most of the time if you want treatment for cancer or to have that polyp removed. And the reason is that prior to treatment for colon cancer, the oncologist who treats it will often want to know the specific type of tumor that you have, the specific mutations that are present in that tumor in order to target the treatment for that tumor in the best way. And then someone asked, might you need surgery to have it removed? If you do have a colon cancer, or in some cases, very, very large polyps that are that we cannot remove on colonoscopy, then you would need to have a part of the colon resected or removed with a surgery. That's part of the treatment for the cancer. There's a question about how we support family members who are being treated. Yeah, maybe you want to address that one, Dr. Young.
Oh, wow. Well, I think, we all try to be there for family members who are going through treatment for colon cancer. I think, as I think about my own experience with family members and, as I recommend things to my patients whose families are going through treatment, there are quite a few community organizations that really offer excellent family and support to the folks who are going through treatment. Some of them are connected directly to places like the Bergen Cancer Center, but what comes to mind is also organizations like Gilda's Club, and Cancer Care New York is another organization that offers a whole range of family and support services to cancer, people being treated for cancer and for cancer survivors.
Dr. Young, if the person asking the question sends us an email, we can get more information and send information about support for families.
I did some research on the CHEK2 mutation. It seems like there could be a slight increased risk of colon cancer with this mutation, but not high enough that guidelines have recommended earlier screening unless you have a family member with the same mutation who has had colon cancer or an advanced adenoma or advanced polyp, in which case that would indicate that you should have earlier screening, just like anyone else who has a first-degree family member with colon cancer.
Yeah, there was also a question about, which may have been about a little bit about stopping colon cancer screening. I mean, we touched on the family history leading to needing to have colon cancer screening every 5 years and starting earlier, depending on when your family member was diagnosed. But what about stopping? You may have mentioned it, but it didn't.
Stopping if you have a family member who's been diagnosed?
If you have a family history. I mean,
So yeah, so the guidelines are very clear about when to stop screening if you've never had a polyp, if you've had negative screening exams.
Yeah,
If you
that's it.
have had a polyp or if you have a family history, the guidelines don't touch on that quite as much. And
Mhm.
once you get into older ages, it becomes, again, a decision between you and your doctor. What are your other medical problems? How high risk does colonoscopy become for you because of your other medical problems? And compare that risk to the risk of you getting colon cancer. As you grow older, colon cancer will be less likely to be the cause of your death than, you know, another medical problem that you have. It's a morbid discussion to have, unfortunately, but this becomes the discussion as you get older about cancer screening. And so it really becomes a personalized decision at that point. And your doctor can guide you through it based on your other medical problems and weighing those risks of the procedure against the risks of getting colon cancer.
Yeah.
Hi, I think there's an important question about alcohol and if it puts you at higher risk for polyps. And the second part of that question is asked about insulin resistance or liver issues, and does that put you at greater risk of colon polyps?
The first is alcohol has
Yeah.
not been found to be a specific risk factor. Tobacco smoking, yes. Alcohol drinking has not been found to be a specific risk factor for colon cancer. Insulin resistance from diabetes is a slight increased risk. So I imagine from liver cirrhosis, it's the same idea that it might put you at slightly higher risk for colon polyps. And then I saw a couple questions about being at a very young age to have a polyp. Yeah, age 18, 19, that's quite young. That would be more rare, and that might prompt some genetic testing if it's that young. But you know, we do see it every now and then, and as I said, early onset colon cancer is becoming more and more common. But that would be considered rare at that young of an age. 18 or 19 years old is young.
Close to that too, Dr. Krigel, is a question about developing polyps, even if you're not at high risk for colon cancer due to family history. Could an individual develop polyps anyway?
Oh, yes.
Yes,
and yeah. So this actually brings up the question, these kind of polyp in just an average risk person, no family history, totally healthy. So the answer to that is at age 50 and now even starting earlier, we expect to find polyps in at least 20% of women and at least 30% of men. So they are quite common. And that's why you know, this is such a you know, this is a procedure that's done so commonly and has been shown to prevent colon cancer.
Because you take the polyps out before they can develop into something worse.
Great.
Okay, so someone asked about a family history of 2 immediate family members with breast cancer and 2 had colon cancer. So do you need genetic testing? Yes. So if none of those family members had genetic testing, then you should undergo genetic testing. The best strategy for genetic testing is to have the person with cancer get that genetic testing, so that if they are, you know, negative for mutations, then you yourself, the family member, know that you actually don't need to be tested. However, if those people are not alive or not able to get tested, then you should definitely be tested. So having a first-degree relative with colon cancer plus another cancer, or, you know, having in this situation first-degree relatives with many different kinds of cancers, including colon and breast, that definitely would be an indication for genetic testing. So I do think that's a good recommendation. At age 70, it becomes less, a little less important for you. However, it's very important for your offspring, because if there is a mutation, you know, you would want your children, of course, to know about it so that they know when to begin screening. Hope that answers that question.
There is also a question about cleansing the colon. Would that be a recommended intervention to decrease colon cancer?
Cleansing of the colon is kind of it's almost a fad like phenomenon. You know, there's thoughts that you know, could that be helpful for your gut microbiome, the group of bacteria that live in your gut? It's not something that I routinely recommend. It's not something that's been shown to, say, prevent colon cancer or even, you know, improve gastrointestinal symptoms that you might have, like bloating or constipation or something like that. So it is not something that I routinely recommend.
And there's a specific question. If somebody's father got diagnosed with rectal cancer at 44 and died at 51, there are 5 children still alive, age 69 to 79. Do we need to be screened? Yes, I would say so. That would be recommended, because that increases your risk because of the family history. But even within that age range, you're still candidates for even routine screening. So that would be highly recommended to see about getting screened.
Yeah, and specifically those who are ages 76 to 85, that's when you consider stopping screening. However, if you've never before been screened and you're between the ages of 76 and 85, the guidelines say it's reasonable to have screening at that point if you've never had it before.
Yeah, thanks for clarifying that.
I would just like to call attention to the chat box. My colleague just put up our number for genetic testing. It's genetic testing at Columbia University, and that's the phone number that you can call to ask questions and see if this is something that is right for you and or your family members.
Someone wrote about cost of colonoscopy and
prior authorization.
Yeah, so so that's true. So for anyone who gets a colonoscopy with us, our department does the pre-authorization with the insurance. If the pre-authorization is not done or not approved, you know, we won't do that colonoscopy because it does cost thousands of dollars. In the range of $7,000 to $8,000 if it's paid for out of pocket. But that is, you know, we generally figure that out with the department beforehand, that pre-authorization is done.
Right, and you know, just also practically, the authorization covers the cost of the anesthesiologist, and so it is something that has to be done with the insurance companies. But actually, I have a question. Can somebody decide that they really do want to get a colonoscopy? Can they go directly to GI department for screening?
They can, yes.
Great.
And we encourage that. That is something called direct to procedure. It's something that was started over a decade. I don't know, much more than a decade ago, because it does increase access to colonoscopy. Yeah. It's one of the ways that we were able to accomplish in New York City, increasing access amongst all groups in the city of colonoscopy, because you don't have to go through a primary care doctor. Right. If you want a colonoscopy, you can actually just call up the Division of Gastroenterology at Columbia or any of the, you know, medical centers, and you can say, I want a colonoscopy, and they'll, over the phone, they'll do a quick questionnaire. They'll ask you your medical problems and the medications that you take, and if you've ever had a colonoscopy before. And if you meet those things where you're healthy, you don't take any medications where, you know, we would want to discuss them before your colonoscopy, mainly blood thinners, and you're due for your colonoscopy, meaning it's been 10 years or you've never had one before, then you are eligible to go direct to procedure, where our office, one of us will just schedule your procedure. You'll get emailed or mailed the guidelines on how to prep. And then the prep prescription I will just send to you. And then you'll come in on the day, meet me on the day of the procedure, and not need an appointment in the office. And this is common practice because it really does increase access to colonoscopy, and it's shown to work.
Yeah, I think that's really excellent, because one thing that people lack sometimes is access to a primary care doctor. And so to be able to go right to the source is a good thing.
And not even needing a visit with a gastroenterologist. I mean, you avoid that as well. You just come in on the day of, you've received the instructions from our office, so you know how to do the prep. And you just come in and have the procedure, and it is a great way to increase access. And then about access, someone asked if there are mobile units available for colonoscopy. Unfortunately, no. The reason is that the equipment required for colonoscopy is pretty complicated. The scope itself needs to be hooked up to large monitors, suction, oxygen. Those things I suppose you could set up in a mobile unit. It's not a bad idea now that I think about it, but I don't know of that existing. So for that reason, no, I don't know about any mobile units for colonoscopy. If colon polyps are rare, okay. Yeah, so how can someone schedule a consultation if you have had a colon polyp at a very young age? Yeah, so that's maybe something, something we could put in the chat, how to get in touch with the GI division for an appointment. So I'm going to put in the chat right now the number for the Columbia GI division, and that I would ask for a high risk genetics consult. Oh, let me see if I can send that to how do I send it to everyone? Oh, panelists and attendees.
Yeah, the drop down at the panelists, change it to everyone. Just hit the arrow down.
Did that work?
I saw it come. Yeah.
There it is. Andrea, I'm not seeing any more questions. Are you? Richard?
I don't see any new ones.
Okay.
Well, great questions, though. And you put in a link to the Cancer Center where people can get the family support.
The link to the Cancer Center, hold on, I thought I saw the email. Andrea, I think you put it in. Andrea, you're muted.
I'm here talking and didn't realize I was muted. I apologize.
Yeah.
I'm sure I put in the
Did.
the phone number.
Okay, great.
And I put in our email in case someone has a specific question.
Yeah, that's what I'm looking for. There it is. It's Columbia Cancer COE, one word, at cumc.columbia.edu. It is in the chat.
There it is.
Put it back into the chat.
Yeah, great. Thank you, Andrea.
And while we're talking, I'm going to have our colleague Maya put in links to all of our other events. We've got a whole bunch coming up in March and April, in both English and Spanish, and you will be seeing them popping up as we continue speaking. The one that just popped up right now is that we do have an email list. So for anyone who wants to just be invited to all of our events that are similar to this and on different topics, please join our email list. We'll send you flyers and links and invitations to all of our health events. And what's coming in now are different, we have a nutrition workshop coming up, we have a cancer prevention workshop coming, and several more. They'll be popping in, and you can just click and register for the event. And you can always share that with family and friends as well. Please do, we encourage that.
Yeah, there's a couple of last questions it looks like rolled in. We don't have a mobile, I don't know of a mobile unit to promote awareness in the Black community. Do you know of that, Dr. Young?
No, I know mobile dental units, but not,
Yeah.
and mobile mammography, but not general mobile units.
And then why are men more likely to get colorectal cancer than women? That's a genetic predisposition, you know, as far as I can tell.
We don't see any more
No,
questions.
no more that I see.
No.
Nope, I think we're good. We did send you we did provide our email address. So if something comes up later on, you can always feel free to email us and we will email you back an answer. And I just would like to thank all of you for being here today. And that includes our attendees and our panelists. You were all super informative and great and wonderful. And we thank you very, very much. This is a great team. I hope we can do this again. Karen, do you want to say anything or anyone else?
I would just like to thank Calvin and Ruth because with their help, most of the people who attended today came in through their work. And they've done this for this presentation and a few before, and I'm hopeful that they will do it in the future as well, because it allows us to get information out to a large group of people who can then tell their friends and families about it. So again, thank you to both Ruth and Calvin for your dedication to this project and others that we do.
Thank you for allowing us to be a part of it, Karen.
Yeah, it's been our pleasure. Thank you so much.
Okay, so I think that this is it. Thank you all, and all of you have a wonderful evening.
Okay, good night.
Likewise. Good night.
Good night.
Good night.
Good night.
Thank you, everyone.